Good afternoon. We will start with our topic, the outcome, CKM outcome with the semaglutide. So speaker is Dr. J.J. Mukherjee. I'll invite you, sir.
Good afternoon at the outset. Thanks to Dr. Jyoti Dev, I think he's not in the hall. And my sincere thanks to Gopika for taking all the WhatsApp messages late at night to make my travel from Kolkata to Trivandrum a success. Topic says CKM outcomes with oral semaglutide. I think those of you who were here for the pre-launch session, you heard injectable semaglutide. You heard the Wegovy launch. Now, myself and my co-speaker, my colleague Dr. Unikeshan will now be speaking on oral semaglutide. So you have too much of semaglutide now. Now, I'm not going to talk about CKM outcome with oral semaglutide. What I'm going to talk about is the basics of GLP-1 receptor agonist. You heard Cheryl telling about diet, right? Honestly, in this room, how many of you stick to diet? Raise your hand. Somebody who sticks to all the things she said. Eat on time in the morning, eat on time at lunchtime, have evening snack, don't eat after 9 p.m., don't have a snack at 1 a.m. I eat, my main food is from 10 p.m. to 2 a.m. That is the time when I'm sitting in front of my computer and I'm eating. So it's hard to do what is being advised. There's no wonder that lifestyle modification is the key to manage obesity and diabetes. If all our patients could do lifestyle modification and they could do proper 30 minutes of exercise, many of us in this room won't be seeing patients. But thankfully they don't. And why do they don't do? There are some scientific reasons for that. So this is Novo Nordisk sponsored symposium, so my thanks to Novo as well. So I'm being commercially supported by them, but I'll try to be as honest as I can. So this is something called CKM syndrome. If you listen to the SGLT2 inhibitor talks, you will hear about CRM syndrome, right? How many of you have been to the empagliflozin talks? I have given hundreds of those. There I talk CRM syndrome, cardio-renal metabolic. So now GLP-1 has to have something different. So they make it CKM syndrome now. Metabolic, cardiac, and kidney syndrome. This is something, a new terminology defined by American Heart Association, not the Diabetic Association. This comes from the Heart Association. I don't think you can read the reference down there. I can't pronounce the name, Dumile. It's a systemic disorder characterized by pathophysiological interactions among metabolic risk factors. It's basically common sense. You have metabolic syndrome, you have cardiac and renal disease. That's called CKM syndrome. Everybody in this room is stage 0. Because as per the new Indian definition, BMI more than 23 is obese. One person in this room whose BMI is less than 23, raise your hands. 1, 2, 3, 4, 5. So you all are not obese. Rest all of us are obese and rest all of us are in stage 0 of CKM syndrome. So start worrying now. You are all stage 0. Stage 1, if you have adipose tissue, how many of you have done your fat percentage down there, which is being done? Any of you have done it? It's being done down below there. You have done, right? Ma'am, for females, more than 30%. Are you more than 30%? So many of us in this room will be obese. So we are already in stage 1. Now come to stage 2. I won't ask you to raise hands here now, but some of you in this room will have hypertension or dyslipidemia or type 2 diabetes. So you're in stage 2. If you have subclinical disease, ASCVD, subclinical heart failure, these are patients now coming to your clinic. They are stage 3. And most of us in this room, unfortunately, manage stage 4. We don't focus on stage 1 and stage 2 and stage 3. The purpose of my talk, if any one of you in this room starts focusing on stage 2 and stage 3, my coming all the way from Calcutta would be served. Because most of us are managing CHD, heart failure, PAD, stroke, and atrial fibrillation. We should not allow our patients to reach that stage. So if you see there's metabolic dysfunction, which is the initiator of CKM syndrome. All of us in this room know the definition of metabolic syndrome. Chronic kidney disease amplifies all that. There's increased risk of CVD in people with type 2 diabetes. Type 2 diabetes with CKD has 6 times the higher risk of CVD. And cardiovascular disease is the outcome. Everybody in this room knows that 4 to 6 to 7 people of type 2 diabetes die a cardiovascular death. So we are trying to prevent a cardiovascular death. We're trying to prevent chronic kidney disease because chronic kidney disease amplifies cardiovascular death. So how can you do that? So this I'll leave. So potential solution for CKM should be lower blood glucose, lower weight, lower decline renal health, decreased cardiovascular risk. So solution for CKM syndrome. The next slide, what you're going to see is not the solution actually. The solution is, how many of you in this room have read the Steno 2 trial? Steno-2 trial, Steno-2 trial. Steno-2 trial is basically managing sugar, blood pressure, cholesterol well, and all the people in Steno-2 had microalbuminuria, so they all got a ACE-ARB. And with that, they showed fantastic reduction in not only 3P MACE, but they also showed that you can increase the longevity by 7 to 8 years in people with type 2 diabetes. If you have not read it, if you're managing diabetes, please go home today and read Steno-2 trial. It's a free download on the net. So now what I'm trying to tell you is GLP-1 RA is probably another one as a solution for management of CKM syndrome. So next 8 minutes will be a little bit of physiology. It will be all about GLP-1. As I told you, I'm not talking about oral semaglutide. Dr. Unnikrishnan is talking. I'm going to tell you about GLP-1. You have heard so much about semaglutide injectable just session before. Yesterday and today morning, you heard so much about tirzepatide. So these are all GLP-1 receptor agonists or twin incretins or triple agonists. So what does GLP-1 receptor and GLP-1 receptor agonists do? On the left-hand side, on the blood pressure, they reduce blood pressure. On the gastrointestinal tract, they reduce gastric emptying. They reduce chylomicron secretion. On the right-hand side, this main action is, of course, on pancreas. It causes glucose-dependent insulin secretion, reduces glucagon secretion, and this is where our patients fail to control their diet, because the professor was just mentioning, we don't eat because we are hungry. We eat because we love our food. The word there is hedonistic eating. Our midbrain, our limbic system, our amygdala. I am from Kolkata. After a full stomach, if I'm about to vomit also, you put mishti, doi and a rasgulla, I will have it. So that's called hedonistic eating. We will eat because we love to eat. Human beings love to eat. All this advice that we give to patients, they try. It isn't it, poor souls. They try for 2 weeks, 4 weeks, they lose 2 kilos, but then they are back to their hedonistic eating. You know, they go to a party, paisa diya hai, itna khana rakha hai, have to eat, isn't it? So this is where GLP-1 receptor agonists work. They work on your brain. There are a lot of centers. It's very complicated, which I'm going to try and show you. Now, GLP-1 receptor agonists, there are so many available. As of now, these are the ones available in the world. Exenatide, Exenat LAR, liraglutide, dulaglutide, lixisenatide, albiglutide. Albiglutide is no longer marketed. It's been withdrawn. Semaglutide SC you heard a lot in pre-lunch session. And we are going to focus on semaglutide oral. See, the point is, a very minuscule percentage of our type 2 diabetic patients get GLP-1 RA, right? Because they can't afford it. But look at the number of GLP-1 RAs available in our country. Exenatide is available, liraglutide is available, dulaglutide is available, Lixi is available, Sema-SC is available, Sema-oral is available. 6 of the 8 GLP-1s that are available in the world, entire world, are available in India. Now think why. So we are not going to talk about the others. We are going to talk about oral semaglutide. This is a very nice review slide, paper. If anybody wants to know about GLP-1, this is the father of GLP-1, Daniel Drucker. He has written a very nice review article. You can take the reference, Diabetes Care 2024, and spend about an hour reading this paper. Very nicely it summarizes the latest, I won't say latest, a lot of papers were presented in AD at this time, almost latest, state-of-the-art of what GLP-1 receptor agonists do. So investigational, let's not talk. They are in phase 1, phase 2 trials. Look at the established benefits on the right-hand side. DKD, MI, HFpEF, stroke. Some part of it will be discussed by Dr. Unnikrishnan when he's discussing the SOUL trial. My job is the metabolic part, which is the central box of the house. Type 2 diabetes, HbA1c, obesity, weight loss. Cardiorenal disorders, again, Dr. Unnikrishnan will be discussing. So actions of GLP-1 receptor RAs on CKM initiator, which is metabolic dysfunction. This is the brain. Why do we eat? There are 2 centers in the brain, in the hypothalamus. The lateral hypothalamus is the hunger center. When that gets triggered on, you feel hungry. And the ventromedial hypothalamus is the satiety center. When that gets stimulated, you feel full. That is physiological eating. But as I told you, we always override physiology. We are hedonistic eating. Only human beings and animals caged in zoos eat for pleasure. Animals in the jungles don't get obese. Why? Because they only eat as long as their hunger makes them to eat. So GLP-1 RA, these are a little bit technical, POMC and CART. These are the neurons which, when stimulated, reduce hunger, energy intake and food cravings, and they inhibit NPY and aggregated peptide, which increases satiety. So when you're on GLP-1 RAs, why do people feel full? They feel bloated. Somebody just mentioned if they After a GLP-1 receptor injection, if they go and eat out and eat a nice rava dosa or idli with a lot of ghee, they start puking, vomiting. Why? Partly because of central actions, partly because of gastric actions. So GLP-1 RA exerts strong anti-inflammatory effects. Just take that message home. No need to see the entire slide. This is too complicated. There are at least 100 papers behind all those small arrows which are written there. Lipolysis, acts on pancreas, it stimulates insulin, reduces glucagon, NFP-kappa, TNF-alpha. I don't want to bore you with that. I also don't understand some of these. They're quite tricky. But there's a lot of research on animals and humans. Just read the lower blue part. GLP-1 RA through some pathways leads to anti-inflammatory effect by down-regulating pro-inflammatory cytokines. So take-home point is GLP-1 RAs are anti-inflammatory. Inflammation drives cardiovascular disease. So you see most of the trials, obesity trials now, they're doing HSCRP. You will see HSCRP is always reported in the obesity trials now. Why? Because if you can reduce inflammation, you can reduce cardiovascular outcomes. And that's what GLP-1 RAs do. I'm talking about all GLP-1 RAs. Beneficial actions of GLP-1 RA on the cardiovascular system. Again, very complicated slide. Humongous amount of work has gone behind to put this slide there. Each and every part has been studied. Improved endothelial function. We say very loosely, improved endothelial function. These studies are very difficult to do. Increased nitric oxide, decreased vascular muscle activation, decreased vascular inflammation, decreased lipid accumulation. These are direct effects on the vasculature. So next time don't ask, why it's preventing cardiac disease, why it's protecting the kidney. These are the reasons. Anti-inflammatory and its direct effects as well as the indirect effects which we all know. Decreases blood pressure, decreases weight, decreases A1C. How does it work on MASLD? Soon you will be hearing in some meeting or the other the various trials. One of them is called Essence trial, where this has shown very good results. How do GLP-1 RAs work there? Just look at that. On the top, metabolic pathway, adipocyte increases triacylglycerol, increases non-nephized, non-esteroid fatty acids, lipotoxicity. Again, the buzzword is inflammation. We talk about steatohepatitis. Titis means what? There's inflammation. There's ongoing inflammation in the liver. The liver keeps fighting the fat, loses the battle, fibrosis ensues. From F0, F1, you become F2, F3, and in the end you end up with cirrhosis. So there are a lot of pathophysiological mechanisms there. One of them where GLP-1 RAs work, and they work. There is a randomized controlled trial. You should be hearing it sometime soon about the Essence trial. So what should you aim for? You all have heard this. All the obesity trials, we say 5% weight loss is essential for a drug to be called an anti-obesity drug. Why? Because if you lose 5%, from the liver part, steatosis and inflammation starts going down. If you can lose 10% of your body weight. So next time a 102 kilo patient comes, don't tell them you're 40 kilo overweight. Straight away patient first. You 102 kilos, you just tell them lose 5%, lose 5 kilos. That will do them immense good. And say you aim for 10 kilos over 12 months. Look at that. If you lose 10% of your body weight, there is decreased steatosis. It should not be called NASH anymore, it should be called MASH, metabolic associated, and decreased fibrosis. So that was part of metabolic action. How do GLP-1 RAs work on the kidney? How do they protect the kidney? Remember, to protect the kidney in a type 2 diabetes, you need good glycemic control, good blood pressure control, good lipid control. They should be on ACE-ARB. They should be on SGLT2 inhibitor. These 5 should be on board. And if they have albuminuria, they should be on finerenone. So after this, we are talking about GLP-1. So how do GLP-1 act on the CKM? So these are the pillars I just now mentioned. Pillar 1, RAS blockade, either ACE inhibitor or A2RB. Pillar 2 is SGLT2 inhibitor. Pillar 3 is finerenone. Finerenone only if there is albuminuria. As of now, we do not have non-albuminuric type 2 diabetic finerenone data as yet. So tomorrow, when you see somebody with CKM, please make sure these 3 drugs are on. Finerenone a little bit expensive, whether they can afford it. I think you already had a finerenone session. Now comes the 4th pillar, which is the GLP-1 RAs. You will soon hear this whole data being presented by Dr. Unikrishnan. How do they work in the kidney? Decrease weight, decrease dyslipidemia, decrease oxidative stress, decrease endothelial dysfunction. And again, the buzzwords, endothelial dysfunction, decrease inflammation. So potential kidney mechanism of action, indirect effects, glycemic control, blood pressure control, weight control, and direct effects are, it causes GLP-1 RAs cause natriuresis, and they also reduce inflammation and oxidative stress. How do they protect the heart? I already told you. It protects the vasculature by those direct and indirect methods. On top of that, again, if you see each arrow, This each arrow, lot of work has been done. On the central nervous system, decrease appetite, loses weight. Liver, decrease hepatic steatosis, decrease circulating lipids. In the kidney, albuminuria is an independent risk factor for cardiovascular disease. GLP-1 RAs reduce albuminuria. They cause reduction in blood pressure to the tune of, it depends which trial you are seeing, anywhere from 3 to up to 9 millimeter mercury systolic blood pressure drop. I think I have 5 more minutes, right? 5 more minutes, oh, that's a lot. Then atherosclerotic plaque, decreases inflammation, causes plaque stability, and in the myocardium, it's got direct action, reduces apoptosis. So GLP-1 RAs have got multiple benefits with regards to cardiovascular protection. Again, don't get me wrong. If you see a type 2 diabetes patient tomorrow, you give a GLP-1, you will not get all these benefits. First and foremost, get glycemic control. Only 30% of Indian type 2 diabetic patients have good glycemic control. We are all responsible. Also, partly patient is also responsible. Half of our patients have blood pressure controlled. Half do not have the blood pressure controlled. It's a shame. So get the blood pressure controlled. Lipids should be the easiest to control. And yet, only 40% of our patients have lipids controlled. This is ICMR data. So first get blood pressure, lipids, and sugar controlled. Then comes the molecules. So on top of that, if you give GLP-1 RA, all the trials which you will read, cardiovascular outcome trials, kidney protection trials, they're all on top of what's called SOC, standard of care. So when you're giving these molecules, make sure you've done your standard of care, got your glycemic control, blood pressure control, lipid control. So GLP-1 RA reduce heart failure hospitalizations. This is the weakest data. With GLP-1 RA, atherosclerotic data is quite good. Kidney data was not there, but has now come very good. All the trials you will hear. Heart failure data is probably the weakest with GLP-1 RA. On the right-hand side is a meta-analysis. If you see, GLP-1 RAs reduce heart failure hospitalizations. Meta-analysis of more than 60,000 patients, about 11% risk reduction. But for heart failure, of course, SGLT2 always scores above GLP-1 RA. So benefits of GLP-1 RAs extends beyond glucose control. Of course, they are one of the best diabetic medications. The one which gives you the biggest HbA1c reduction is the magic injection called insulin. After insulin, probably GLP-1 RAs are the second best, which give you the biggest value for your money, reduction in HbA1c. On top of that, these are the extra glycemic benefits. Heart and blood vessels. I've taken you through the data. Cardioprotection, endothelial function, plaque stability, blood pressure, vascular inflammation. I did not show you platelet degradation, reduces lipid accumulation. Pancreas increases insulin secretion, which is glucose dependent. That's why hypoglycemia is very low, decreases glucagon secretion. Now, stimulation of beta cell proliferation and reduction of beta cell apoptosis. This is not human data. This is animal data. There is some data that, yes, it protects beta cells, reduces beta cell apoptosis. And on the kidney, increased diuresis, increased sodium excretion, and of course, the indirect benefits of glycemic control and blood pressure control. Brain, it acts to reduce the appetite. It does reduce the risk of stroke. Those of you who remember the SUSTAIN 6 trial of injectable semaglutide would know that. And it impacts body weight. And coming to the liver, this is the big thing now. On the liver, the GLP-1 RAs and also the other ones which are coming have nice effects. And we are beginning to show that they can reverse fibrosis. So GLP-1 RAs are globally endorsed. On the left-hand side, on the top, those are the liver association. On the right-hand side, that's the kidney association. Down to the right, that's our ADA ESD. And on the left-hand side, it's cardiac. So everybody wants to steal SGLT2 and GLP-1. Kidney doctors say it's ours, cardiac doctors say it's ours, but we should fight for it, and we say it is an endocrine and diabetes drug, and we are lending it to you to use, okay? So from tomorrow, you say that. Now, the last part, evidence of oral semaglutide. I've got 2 more minutes. So there's significant HbA1c reduction with oral semaglutide. There are 8 pioneer trials. There are a lot of preclinical trials. If you see, the maximum HbA1c reduction with oral semaglutide is up to 1.5%. Minimal is 1.1, maximum is 1.5. Remember these values, these are quite high, 1.1 to 1.5. And these are people who are starting with a baseline HbA1c of 8, 8.5. So that's quite a good reduction. And maximum weight loss, these are type 2 diabetic patients, mind you, not obese, non-diabetic. Type 2 diabetes, weight loss is difficult. It's half compared to non-diabetic obese person. And even here, if you see, you can get up to from 3.5 to 5 kilograms weight loss. Remember, 5%, 10%, 15% weight loss. Higher proportion of participants achieve composite of HbA1c reduction more than 1% and body weight loss of 5%. If you see Pioneer 1, which was with placebo, almost 40% got it. Pioneer 2, head-to-head comparison of oral semaglutide with SGLT2 inhibitor empagliflozin, statistically significant. That star mark on the top is statistically significant reduction. Composite of more than 1% reduction and body weight of 5%. Pioneer 3 is compared with sitagliptin, and Pioneer 4, they've done head-to-head comparison with their own molecule, liraglutide, and they've shown oral semaglutide is better than liraglutide with regards to achieving the above outcome. I'm just finishing on my time. I'll just take 2 minutes extra, Chairperson, sir. Okay. So cardiovascular risk factor reduction with oral semaglutide. I told you the buzzword is inflammation, inflammation, inflammation. That's why on the top is HSCRP. There's unequivocal evidence data from all the pioneer trials that if you use oral semaglutide, there is reduction in inflammation, reduction in lipids, and reduction in systolic blood pressure. And the most important thing is central adiposity, almost 5% loss. That is almost 2 inches. Oh my God. So last slide, choosing the right anti-diabetic agent for management of CKM. First and foremost, lifestyle, 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 exercise, 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 metformin. After that, even a second-line drug could be a GLP-1 RA if the patient can afford it. Why? Good glucose, the comparison is made with SGLT2, DPP-1, metformin. The number of pluses tells you how more effective or less effective it is in comparison to the other molecules. Glucose lowering efficacy. Effect on body weight, 3.5 to 5 kilograms weight loss. CV risk factors reduction, I've taken you through in the last 15 minutes. Pleiotropic benefits, and almost no risk of hypoglycemia. So with that, I'm setting the stage for use of oral semaglutide in people with type 2 diabetes, and whether it delivers the kidney and heart benefits. Oral semaglutide, you already heard the injectable semaglutide data pre-lunch. Does oral semaglutide also do that? To highlight on that, Dr. Unnikrishnan, over to you, sir. I stop here.
Thank you, sir. I think we'll take up the question at the end of the session.
It's the same. Cardiac kidney metabolic, cardiac renal metabolic.
I now invite our chairperson to give away the token of appreciation to Dr. Mukherjee.